I'm back in plenary session. I'm joined via Zoom by Chris Booth. There's nobody better. The audience gets what they want. Chris, it's so good to see you.
Thanks for having me back, Vinay. It's a pleasure to join you again after just a short break since our last chat.
It's just been a short break. Chris is, of course, professor of medicine at Queen's University in Kingston, Ontario, Canada. He is a practicing hematologist, oncologist. No, just medical oncologist. In Canada, they have the good sense not to delve into the heme world. And he is a GIGU oncologist. Chris, pleasure to have you back. One of the few people who has sat in the hot seat, guest host of this show.
Yes, and as listeners may recall, I'm still looking for my family as we got lost in the forests of Oregon about a couple years ago now on the famous Seven Waterfall hike. And your interviewing skills while you drove were better than your cartography skills. Let's just put it that way.
Yeah, a little few wrong turns. Well,
Yeah,
now I'm back. I'm out of the woods of Oregon.
yeah.
So, Chris, we're going to talk about a new paper that's coming out any day now. Maybe at the time of this recording, it's just come out. But first, we were going to talk about the questions that listeners have been asking me. You know, listeners ask, they listen to Chris Booth. They always love when you come on, but they have a lot of questions about career, life in general. And so I thought I might pick your brain a little bit. First question. You know, for somebody in hematology oncology, how does that person make the decision of a career in academic hemonc versus going into practice? How did you make that decision? How should they make that decision?
Great question. So if I think back to my career evolution, I knew at a very early age, primary school, I wanted to be an internist. Just joking about that. But so it was pretty easy for me in medical school to know I was going to go the internal medicine route. And then I think you and I have discussed this before, but I had a very last minute detour into oncology, very last minute.
I see.
We'd already been interviewing for other positions, and I loved all areas of internal medicine. In fact, was going to be an ICU doctor and palliative care doctor, and was interviewing for those fellowships. When
Wow.
at the last moment, I had an elective, an outpatient oncology elective at Princess Margaret Hospital, and at that time, most internal medicine training programs in Canada, we did not rotate through the outpatient center and the cancer center. We were on the wards looking after end-stage patients with cancer, which I found gratifying and intellectually and personally satisfying, but it wasn't something I necessarily thought I would do full-time for a career.
I see.
And for a number of reasons, I had this outpatient elective late in my PGY3 year. So we
Uh-huh.
interview in the fall of PGY3 for subspecialties. I'd already interviewed for critical care, and at the time thought I was going to do an ICU palliative care hybrid, and then did a month of clinic at Princess Margaret. But it was on day two, at the end of day two. I probably told you the story, but I walked down the hall, put a quarter in the payphone to call Celeste, and said, I think I want to be a cancer doctor. And she said, you should think about it. It's been 2 days. I said, no, the application was due 6 weeks ago. Anyhow, long story short, they humored me and gave me an interview at Princess Margaret and University of Toronto, and let me into their program. But so my career path was a little bit of serendipity, I guess, keeping open-minded to different things. But I guess coming back to how I landed what I'm doing now is it was these very rich, we've talked about this before, this very privileged position we have as oncologists to share these poignant moments with our patients. And it was that rich human connection that I could tell within 2 days that's something I wanted to do for a career. I knew I would never get tired of that. And the science and epidemiology and other elements of cancer care are also interesting, but it was the very real human connection. So I guess kind of getting back to your question about how
Uh-huh.
one might consider approaching different career paths, what I tell the
Yes.
students is just to keep an open mind, because I know there's a huge amount of pressure, coming out of high school to know you want to be a neurosurgery resident of the cerebellum, but to try to resist that pressure and to try to keep open-minded, because the reality is I tell the students, just remember that moment when you got the letter or the email telling you that you were accepted to medical school
Uh-huh.
and how you felt. All of us were just thrilled. All of us just wanted to be doctors. And at that time, there was probably a whole list of different types of medicine we would have been thrilled to practice. And it becomes a little bit artificial later in medical school or residency where, there's this culture where I could only be an orthopedic surgeon, I could only
Right.
be a nephrologist or
Right.
something like that. The reality is many of us, including myself, and I'm sure you too, would be very happy in many different areas of medicine. So try to resist that pressure early to pigeonhole yourself, because you might have these kind of career opportunities or pivot points that allow you to make different decisions. So retain an open-minded approach. I guess the power of mentorship. I've been very privileged to have some amazing mentors who have opened doors and opportunities for me and allowed me to see career paths in different ways.
Mm-hmm.
And so I think that, finding someone you connect with, and the way I approach now that, I'm getting on in my career and I'm, often the one giving advice, although I still touch base with my mentors regularly,
Yes.
is when a student or a resident comes to me and wants advice and wants to work with me either clinically or in a project, I'm very upfront.
Yeah.
And I tell them, I say, look, we're going to start working together. And my goal is to support you in your career. And if you decide you want to be an oncologist or go into internal medicine, that's great. And I'll be really happy. But at the end of the day, I want to help you find what it is you want to do. So I never want you to feel pressured that you have to tell me that you want to be a GI medical oncologist or internist at all. If
Uh-huh.
you tell me after our time together that you're falling in love with psychiatry, family medicine, obstetrics, I'll be thrilled, because at the end of the day, we just want our students and trainees to find the area of medicine where they will thrive. And so that's why I often approach that is, let's just find an area where people are passionate about it. The other thing I encourage trainees to think about is where you want to live, where you want to work. If you're going to keep training yourself into an uber specialized niche,
Yes.
then that job market will dictate where you live and work.
I see.
And this is really important because, as I said at the outset, there's many areas of medicine we all would love, and we need to think about the family and life side of these decisions as well. And you have to be prepared to balance having control over where you live versus the career that you want. So I think that's obviously something important. Then, lifestyle, how hard you want to work. I think there's much different gradients in income in medicine in the US between different specialties. We certainly do have that in Canada, but I think to a lesser extent.
I see.
And so these are all things that certainly that I considered kind of in hindsight and sometimes, prospectively as I was going through decision making as well.
I see. I see. That's interesting. And I've heard you talk about this before. And I just want to point out that, your mentors must have been really something special because, they had to work with you, Chris. So that's really had to overcome whatever deficit they started with. They overcame it.
No kidding.
Okay, but here's my question then. So I mean, I think you're really good. I mean, to be open-minded about the fact that it doesn't really matter to you what the right specialty is for a person. I think you're right. But what about the choice? I guess in Canada they could choose to be in a private practice situation or in the academy. How do they make that choice?
Again, most trainees who come to me, they gravitate towards me because I tend to do a lot of academic scholarship and research. So
Yeah.
they're coming to me for those types of projects, and often they have an idea they want to do that for a career. But I'm also very clear and say, you know what, the goal of this project is to have fun, to learn something, and kind of open your mind to what a research career might be. And a very large proportion. I should go back and do a highlight and color code exercise like
Yeah.
we talked about before.
Yeah.
Amongst the trainees I've worked with, how many actually end up doing kind of serious academic work, and some become, superb clinicians working in the community.
Yeah.
I'm guessing it's half and half.
I see.
And I think that, one of the problems with academic medicine is we celebrate the research superstars and maybe to a certain extent the educational stars, but at the end of the day, clinical care is the most important thing that we do.
Right.
And it bothers me that is not acknowledged or recognized enough within the academy, and it should be, because it's the cornerstone of everything that we do. So I have a very similar conversation with trainees about what it is that you love to do. Is it patient care? Do you want to have more or less control over your schedule, more or less control over where you live? There is an income differential, but it's not nearly. I mean, you and my colleagues in the United States take a huge income cut to work in the
Thanks for
academy.
reminding me.
Yeah, we do
Yeah.
take an income cut to some extent. In some specialties, it can be quite substantial, but it's much less so than the United States. And I guess the other consideration is, how much more training do you want to get? So this is something I can push back on you, because I was reading something you wrote once, and you and I have had this dialogue offline, but let's put it out there for the listeners to see.
Okay.
Prasad taking a few punches from Booth. So, I think the gist of it was something like there's nothing that you can learn beyond your clinical training, and any extra fellowship training is a waste of time. And I retract that. I
I
said,
remember
wait a
this.
second, Vinay, wait a second. So let's take a step back. And I do partially agree with you. I partially agree with you.
Okay.
In Canada, if you want to get an academic job, there is an expectation that you will do some advanced training. Okay. And so in our world, in oncology, just like you, we do 3 years of internal medicine. And then we're not as smart as you guys. We can't handle both blood and solid tumors. So we have to pick one. But
Uh-huh.
we learn it in 2 years, not
I
three. So
see.
anyhow, so then we do 2 years of heme or
Yeah.
solid tumor med onc.
Yeah.
And then you're qualified. You pass your exams, you can go get a job in the real world.
Yeah.
Generally now, if you want to get a job at an academic center, you're expected to have something additional. And that could be a year of advanced clinical training, research training, educational training, something like that. So there's an expectation. And I know that there is creep within medical education to add more and more layers to this. And I totally agree with you that there's nothing that I would have learned in, put it this way, I don't think you need an extra year of breast cancer or colon cancer clinical training
Uh-huh.
to be ready to be an academic star in that area. I think, some of my colleagues might be annoyed that I said that, but
Uh,
what we do is not rocket science. We've been well trained for many, many years. And the reality is in your first couple of years as a junior attending, you're going to be overwhelmed and lost periodically anyhow, and you're going to be a steep learning curve, and you just ask for help and read around cases. So I'm not so sure that that has super high value. And I think those were the types of fellowships that you were mostly talking about. But the fellowships I think that have real
yeah.
value, because we go through training and we learn how to become good clinical doctors. That doesn't mean we're good teachers, we're
Oh, yeah.
good scholars or researchers. And
Correct.
so the fellowships that I think have the most value post clinical training are ones which give you new skill sets that will benefit the academy. Ideally, hardcore, serious educational scholarship, teaching, but really kind of educational scholarship, how to design curricula, new residency programs, models of teaching, et cetera, or research methods. Now, it might be going to the lab for a translational career. It might be learning epidemiology, biostatistics, health services research, or a clinical trials fellowship. So there we go. So there's Booth's long-winded rebuttal to Prasad. Over to you. Take that. What do you say?
I'm interested. I wonder if, one of the reasons why we have different feelings on this initially, although I think we were probably closer than we would, initially admit. Um, but I wonder if one of the differences is a US Canada difference. I don't know. I haven't thought about it all completely, but my understanding is this is something somebody from Ireland told me because, I trained at the NCI. They have a lot of Irish fellows. And they said, I was like, well, why this person was a superb clinician, really good at research. I didn't think this person could be taught anything. This person was that good, one of the stars in Ireland. And she came over nonetheless to come to the NCI and redo training. And I'm like, why do so many Irish come to the NCI and do all this training? And she said, well, the truth is there's just not that many medical oncology jobs in Ireland.
Yeah.
Like you have to wait for a job to open up.
Yeah.
And she says, and I don't want to push someone down a flight of stairs. So I have to wait a while for the job to open up. Yeah. And so the same thing, I think to some degree, the labor market is different. In the US, of course, the number of spots for medical oncologists is very open-ended, and so they can always create some more spots. I think in Canada, it's probably tighter, especially in the academic centers. Like you can't just snap your fingers and have a spot. So that might be part of the difference why people in Canada gravitate to the extra fellowships. And the other thing is like the relationship between your debt. I don't know about you, Booth, when you go from like for those of us in the United States, we often have just a ton of debt by the time we're looking at that first job. And so one more year at $70,000 versus a year at faculty pay is a big difference in terms of interest and such. So I wonder if that might be a little bit, but I mean, you and I both agree you need, if you really want to do research, you're going to need to know a little bit more than what you get in a typical med-onc training.
Yeah, no, I agree. And there is definitely, I got through medical school in the era just before tuition really went haywire. So I was very privileged in that sense to train in an era of minimal debt. It's very different now. And so there is that pressure for sure. But I guess if you take a step back and say, what do we want academic physicians to be doing? We want them to look after patients really well, and they're ready to do that after their PGY 5 or 6 year. We want them to be really, really good teachers. They may or may not be ready for that. And we want them to do research. And if they don't do any training in that, we wonder why a lot of people in academic medicine are not, they might be superb clinicians, but they're not contributing in a major way to education or research. Well, it's probably because they haven't had either enough mentorship or some training in that. So I'm not saying everyone needs to do a 1 or 2 year fellowship. but I think that there are benefits to doing it. But I will go back to emphasizing that I think the core mission of academic medicine is still looking after patients. And a lot of people will be more than ready to do that after their clinical training, and they need to find a niche of what else they will do in the academy.
Yeah, and I think that in my mind, the best research is with that same goal of looking after patients, because you're fighting about what it means to look after patients well. That's literally at stake in the research. But let me ask you this. I mean, I was just listening to some podcasts, and I don't, I like to listen to other oncology podcasts and other podcasts broadly, but this podcast, we're talking about academic careers in oncology, and literally the only mindset of the podcast was the industry clinical trialist. It was, I mean, I don't even know how to explain it. Like, the people having the dialogue, they were all sharing the idea that the only thing that means to do scholarship is to run uncontrolled phase 2 studies. I mean, I think that's what they had in their mind. And so the whole dialogue revolved around that. And the question was, how do you balance your portfolio of uncontrolled phase 2 studies? How many industry-initiated uncontrolled phase 2s and how many investigator-initiated uncontrolled phase 2s? And the reason I say that is because, the truth is that probably the phase 2 is the majority of their practice, and a little bit of phase 3 for these global randomized trials. But to be honest, the CROs are recruiting vigorously globally for those. And then a little bit of phase 1, but often they delegate that to a member of the group. Okay, so, I don't know. What I want to raise here is this issue of like, well, what does it mean to be an academic oncologist? I think most people are increasingly thinking about it as if it means you run those studies. So you see patients, and as much as possible, you put patients on those studies, and you run those studies. But you and I have a different conception of it, because we think an academic oncologist means Ian Tannock, Elizabeth Eisenhower, a person who sees patients, is a consummate clinician, somebody who, I know in Ian's case, ran a lab. And I don't know about Elizabeth. Did she run a lab, or is she just very knowledgeable about laboratory science? So yeah, they either run a lab or they know a lot about laboratory work. They see patients. They increasingly learn about regulatory processes, and they put it all together, and they come out with these devastating papers where they ask us to reconceptualize something that we take for granted. And to be honest, that's what you do too. In the paper we're going to talk about, which I think is really asking us to reconceptualize that in a 30,000-foot view of oncology. But I think the reality is, like, when people think about academic medicines, this thing, that's not what they're thinking about. They're thinking about, how do I get my name as last author on a JCO paper that's a trial of, the 7th BTK inhibitor in CLL, or the 4th VEGF antibody in colon cancer, or whatever, What would you say to that?
So what I would say, so this is probably going to piss some people off.
Good. That's why you're here, Booth. Piss them off.
So I would say that hardcore clinical trialists who actually write their own protocols, come up with novel questions, and move forward with clinical trials, that's serious hardcore academic oncology. Putting patients on trials that have been conceptualized, written, and designed by other people, there's nothing academic about that. It's important, and all of us have done that because that's how clinical trials get completed. But the idea that would define someone's career and make them a hardcore academic, I would challenge. I would say that there's a role for that, and I would say that if someone's doing that in the academic setting, that's an expectation. But if they're truly contributing to the academy, I would hope that they have something else they're doing. A lot of teaching, maybe designing some of their own in-house studies. But I agree, putting patients on other people's trials, it's a necessary component of what we do, and it's an important one. But I don't think that's the epitome of academic medicine. Unfortunately, wow. I think that's what brings in the dollars.
Yes.
Especially in the context of U.S. academic medical centers. So it brings in the dollars. And it's also a lot easier, Vinay. Like, I mean, as you well know, right? Writing your own grants, building your own team, getting rejected over and over again, that's hard. That's very, very hard. Yeah. And if someone comes and says, we have this protocol, you can put some patients on, you might be able to tweak the protocol, we're going to fly you to Hawaii to talk about the protocol for 3 days, and if you put on 40 patients, you'll get your name in the middle of a New England Journal protocol. Like, geez, you got to wonder, like, why wasn't Prasad smart enough to say yes to that? And
that's what I wonder.
So, I mean, because when I decided to or go out on the career path I had. Bill McKillop sat me down, one of my formative mentors, who was
Yeah.
a hardcore health services researcher, and he said, Chris, there are much easier paths. And he said, you can have a very gratifying career in academic medicine with a much easier path. I just want to make sure you know what you're getting into. And it's not like it's been a total slog, but there's been challenges. And I mean, that's some of the joys of being in the academy, is the variety, right? And we haven't talked about, but the privilege, privilege of oncology is looking after the patients. The privilege of being an academic physician is working with the students and the trainees, right? That's what I love. And then having dedicated time each week to be able to think and write and to be creative and to imagine how we might be able to modify the system or the way that a disease or a treatment is conceptualized is, it's a wonderful opportunity. As you and I have said many times, we feel very fortunate to have this type of job, despite the fact there are some headaches occasionally.
I mean, obviously the listeners are going to know why I like you so much, because everything you said is exactly what I would tell people, which is, yeah, that to me is not what it really means to do academic work. I mean, I appreciate it; it's well received. I'm sure it brings people money, but that's not really academics. Academics is you have to push back, and I would even go for. I mean, I want to give them the pep talk. Here's my pep talk, and maybe you'll give a pep talk too. Why should you do this kind of stuff? There's a fellow named multiple myeloma named Mani, who listeners will know very shortly, because he's going to come on this podcast because we have like several papers in the works. And he listened to this podcast. He read the book Malignant, and he is a multiple myeloma guy, or he's a budding multiple myeloma guy. He's going to start his first faculty job. And he emailed me and had a bunch of ideas for ways we can build on some of the themes of, my work is an extension of your work, and your work is an extension, of Ian's work, and that kind of stuff. And he's building on it in his own way. And he reached out to me, and every one of his ideas, it really, it pushes on something in the field. He's challenging something in the field. It's all about how can the trials better serve the patients and not serve the trial sponsors. And I want to say, like, one, I think that is, it's more interesting. Like, you're going to have a more interesting life if you do these kinds of things. You're going to have more to think about and debate. Two, I think you have a moral duty to do that. And that's what I will argue, which is that we are taking care of vulnerable people. And in fact, they're so vulnerable that our society has, created all these regulatory apparatuses to protect dying people from choices that dying people would once make themselves out of desperation. We shield them from, drugs that don't have safety testing, or drugs that don't have proven efficacy, when we come to approved drugs, because we know sick and dying people can make bad choices. That system has to some degree been co-opted by for-profit interests. And the only person in this whole system I see who has sworn a goddamn oath to do what's best for the patient is the doctor. We have sworn that oath, and that extends not just to your bedside manner and how you treat individual patients. It extends, I believe, to your entire career, that your oath means that at every juncture, you feel like there is an injustice going on, be it the promotion of ramucirumab for something it doesn't do a lot in, high cost, missed opportunity cost, something that you and I will probably talk about again in the future, low value care. You have an obligation, I think, a special obligation to your profession to find that, articulate it, persuade others that it's a problem. And that is academic work. And that is really important work. And I don't know, this profession has been greater because of the people who have done that. Bernie Fisher did it. Ian did it. Tito did it. All the people, Elizabeth did it. Elizabeth did a lot of wonderful stuff. I mean, all the people you and I admire are not just the people who put the most patients on trials. They're people who saw some misalignment in the incentives, and they wanted to draw attention to it and persuade others that it was a problem. Now, what's your pep talk for them, Booth?
Yeah, I agree. So two follow-up thoughts. The first is something you mentioned about your colleague, the junior fellow in myeloma. So just for the trainees listening, so this fellow sounds unusual in the sense that he is actually putting forward innovative and important questions and research ideas at a very junior stage. And that's impressive and exciting. But just because often I hear trainees who are considering going into the academy tell me that, well, I don't feel like I have a lot of good ideas. So just to reassure your listeners that the myeloma fellow is probably an exception. Vinay Prasad probably had some ideas. Some were good and some were bad. But I can tell you, I had some ideas, but a lot of the projects I did when I was a resident and a researcher, almost all of them were concepts that were really kind of germinated with my senior mentors. And then we developed them together. And then, even now, my current fellow, in an informal conversation just said, I wonder, I don't get these ideas like you do. And I reassured him, I tried to reassure him and said, I didn't necessarily either. I don't know if this comes with kind of age or wisdom or experience, but I just wouldn't want your trainees to think that just because they don't have brilliant ideas for projects at this stage doesn't mean they're not cut out for a career in academic medicine, because I think that's something that comes with time and experience, and when we become a master of a certain niche area, there's logical questions that flow from it. So that's one point I wanted to elaborate on. The second is, I think what you're getting at is, this opportunity that we have, and almost, obligation, is that, practicing medicine in general and having an academic job is one of the most privileged positions in society. And, it is, everyone had to work hard to get to this position. Some people had to work a lot harder. I consider myself, having come from the background I had, incredibly privileged, and try to keep that in mind when I make career choices. And I think recognizing the joys and the privilege of having a career that are satisfying, we get well paid. It's very hard to lose your job. You'll always be able to find work, and you can.
I'm working on it, Chris.
Yeah, you have the reward and gratification of looking after patients. It's a wonderful privilege, and I think whether that's in community practice or in the academy, having that mindset, I think, will help sustain some of that kind of fire in the belly that you just described. And whether it's, you're a hardcore clinician doing the best you can and advocating for your patients and your community of patients at your busy general hospital, or you're pushing the envelopes with new ways of teaching, thinking, writing, or researching in your area of medicine, I think that's, that's where those ideas come together.
That's really well put. And you're good to point out that, you're not going to have those ideas on day one for like what to study. And I think to some degree that comes with, that's the hardest thing to learn, where to put your energies and what's important. But I think the two things that a trainee can bring are often, fresh eyes. They can see things that you take for granted. Two, enthusiasm and energy that as we get a little bit along that you don't always have. And I would say the only advice I tell people is like, it's easy to run the first 3/4 of the mile, but the most important is that last quarter mile. And I think that so many great projects, it was, the difference between like no product and a product was the sticking to it, putting up with a few rejections and pushing it forward anyway. And that last quarter mile. And I think if you're willing to do that, then, you'll learn as you go.
I couldn't agree with you more. And as a former elite level middle distance runner, I can tell you that last quarter mile, I was a 1500-meter man in university and high school, and that last lap is hard. And you're right, having a good team to get you through. And the other way I frame it, when I meet with a trainee who has an idea, I say, let's talk about an idea, and then we come up with a general idea, and I say, I want you to go away for a couple of weeks. I want you to think about this and write a 2-page proposal. And that's kind of a litmus test. And then they do that and come back, and then we take it from there. But yes.
Interesting. I do similar things that like a litmus test. I won't reveal my secrets on the podcast. Okay, now let's talk about the paper that we're here to talk about. This is a project that I'm very grateful you included me on. Maybe I contributed something, but my idea, I don't know, maybe it didn't contribute as much as I thought. But this is a project that, you've been working on for a long time. Well, I guess maybe I should be honest about how I first came across it. I think when I was a fellow, I had this question one day, which was, gosh, I hear about this PFS all the time. I hear about it all the time. Was it always so popular? What the hell is it? And so I started reading about it. And of course, I came across your, legendary commentary. But then I also came across that paper by the first author is Kay. K-A-Y. You're the last author. The Evolution of the Randomized Control Trial. I think this was an Annals of Oncology paper, was it?
2012, yeah.
Yeah, and so I came across this paper when I was a fellow. And the paper, the reason I loved it was Booth had done some interesting things. He captured what was the primary endpoint of a set of randomized controlled trials in oncology in different periods of time. And as time goes on, sure enough, the response rate diminished in popularity as an endpoint. Overall survival also diminished, but PFS more than made up for the rest. Time to progression and PFS, those two composite primary endpoints made up for the rest. And the other interesting thing that I used to always find so fascinating from that paper, which is one of the publications of this project, was the percent of studies that are industry funded and the sample size of studies. And both of those marched together in lockstep upwards, suggesting that when the industry gets more involved in studies, they power the crap out of them to find statistically significant, but perhaps clinically dubious distinctions. And this is the update of that. Joey Del Poggio led this huge effort, and Chris, to look at the randomized controlled trial. So I wonder if you might talk a little bit about, you always love these stories. Where were you when you had the idea? How you started doing this? And this is the third update of the paper, is that right?
Yep, this is it. So that's a great introduction. So this is the third paper in a series. Now, this has been published the first one was published in 2008. The second paper was 2012, and this one will come out next week in HemeOncology. So the idea started very early in my training when I was in Dr. Tannick's clinic, and the ATAC trial had just been published. I saw a woman with breast cancer and presented the case to him, and he asked for my management plan, and I said adjuvant and anastrozole. And this is a story I've probably told you before, and I said, well, Dr. Tannick, we should give anastrozole. And he said, well, what about tamoxifen? And I said, haven't you read the ATAC trial? Anastrozole is way better.
Yeah.
And he said, young oncologists are increasingly impressed with smaller and smaller benefits. And I said, do you have any data to back that up? And he said, no, but you're going to go find it. And so that led to this first project, which was the evolution of the randomized control trial. So that conversation took place in 2005, and we decided to go back 30 years. We chose 1975. I don't know, maybe because that was the year I was born. But anyhow, we went back to the mid 70s, and we had 30 years of trials from 75 to 2004. And we tracked endpoints, effect size, power, sample size, funding, and found a number of important observations as you have summarized. One of which was one of the earliest descriptions of so-called sponsorship bias, which is that even when one controls for the effect size, the p-value, and the endpoint, industry trials are more likely to be strongly endorsed as representing a new standard of care. So that was published in 2008 in JCO, and that was actually pivotal for me in the sense that it was probably the first quote unquote meta research project I did, and also allowed me to work with some amazing colleagues. And then I moved to Kingston and did a research fellowship. And then in 2010-11, as junior faculty, we thought we would update it. So we called the first block from 75 to 04, Evolution of the Randomized Trial in the Area of Cytotoxic Therapy.
Right.
We did an update. Amin Kai was one of our residents. So it was 2005 to 2009, the era of molecular oncology, right? This is when all the targeted therapies were coming out. And then, so that was published in 2012. And I think, it was probably you and I, maybe on the waterfall hike or earlier, where I think actually you called me out in one of your lectures publicly. You said, come on, Booth, we need to update this. And so
I did call you out on one of my episodes. I said, where's the update?
I was like, geez. So of course I turned to the legendary Joey Del Poggio, as I like to refer to him. And Joey was one of our trainees, trained at Queen's and Princess Margaret, and is now a busy community oncologist in Northern Ontario and Thunder Bay. And so, and Joey's done a lot of work with us, and so he led this. And I guess just to acknowledge the team, so this, we briefly, the concept was to update it. So we had the cytotoxic era up to 04, the early targeted therapy era up to 09, and we said, well, let's look in the last decade, the era of precision oncology.
You mean game changers, Chris? Game changers.
This is it, game changers, game changers. So the team was Joey, who led the work, John Barry, who was a summer student, who did a lot of the data review, Wilma Hopman, who's a biostatistician, who does a lot of work with our team, and then a strong supporting cast of characters with a major interest in this space, yourself, Vishal, and Elizabeth Eisenhower. And so it was a great team of people with kind of common interests. And so I guess just to briefly summarize kind of the approach, and we can talk about the results later. When we had designed this in 2005, we said we want to look at practice-changing trials, and it'll be overwhelming to look at 30 years of trials in every cancer. So let's choose the major sites. So this is an overview of trials of systemic anti-cancer therapy in three major cancers: breast, colorectal, and non-small cell lung cancer, published in major journals. And we can be criticized for that, but we had to draw the line somewhere, else it would become overwhelming. And we actually wanted to look at quote unquote practice-changing, widely read trials. And so I think it was reasonable to restrict it. So we kept updating it with the same diseases. So the current study looks at trials of those three diseases published between 2010 and 2020 in 7 major journals, the usual journals that we would expect, some of the general journals, the New England, JAMA, and Lancet, the specialty journals, JAMA Oncology, Lancet Oncology, JCO, and JNCI. That was kind of where we started. We had we wanted to update it, look at how things have changed over time, and we had a few variables of interest that we also explored that were new.
So that is interesting. So now I am a part of the legacy, the long legacy. But you know, it's such an interesting paper. We found so many things, and we looked at a couple of things that we have never hitherto looked at, and that's what I'm going to get excited about. But I think this is telling because, what we design and power our randomized studies for, and what we find in these studies is a reflection, I think, both of the drugs that are developed, but also of the human side of science, the way in which we choose the targets, we choose, duplicative Me Too drugs versus first-in-class drugs, the way we run our agenda. So I don't know, where should we start? I guess this podcast is going to, it's going to come out when the paper appears, right?
Mm-hmm. Yeah.
Interesting. So I can't post it right away, huh?
No. So the paper's today's Monday. The paper's coming out next Thursday, March 25th.
Oh, what a buzzkill. You haven't given away any of the results yet.
No.
Should I separate my recording into 2 parts? This is part 1. We can put this out right away. And part 2 is going to be when the episode drops.
It's totally up to you. Whatever you think.
Do that.
Yeah.
All right. So concludes part 1, which I'm going to release right now after I finish this interview. And part 2, Chris Booth breaks open the embargo and tells us all the secrets inside. All right, stay tuned.